the 3 co-conveners of the Alliance for Gender Equality and UHC, along with Women Deliver and Spectra Rwanda. The subject of our dialogue today is visioning strong health systems built on women's rights, as we look forward to the 2nd UN high-level meeting on UHC in 12 months' time. The world has changed since heads of state and government met at the high-level meeting on UHC in 2019. We are still grappling with a pandemic that has devastated people, health systems, economies, and disproportionately affected women and girls. Inequality has increased between and within countries. But one thing has not changed. As the title of this event states, strong health systems must be built on women's rights. In 2019, over 100 NGOs from all regions joined together to form the Alliance for Gender Equality and UHC in the lead up to the first high-level meeting on UHC. We wanted to make that point and to advocate for gender equality, women's rights, including the rights of women health workers, and to advocate for sexual and reproductive health and rights as the foundations for strong health systems. In 2019, the Alliance effectively supported the inclusion of language on gender equality and SRHR, women's leadership and the role of women in the health workforce, in the final declaration of the UHC political declaration. We also supported a joint statement by 58 countries voicing strong support for SRHR as a cornerstone of UHC. The Alliance continues today as a space for collaboration and coordinated advocacy of civil society member organizations representing over 60 countries to advocate for gender responsive UHC in policies, programs, and dialogue. UHC has the potential to transform the lives and life chances of all women and girls, but millions face social and financial barriers to accessing the quality of the health services that they need throughout the life cycle. In addition, although women hold the majority of health worker roles, they're marginalized in leadership from community to global levels. The health needs and perspectives of women and girls are regularly overlooked in health systems decision-making, including in UHC. And these deficiencies have been exposed and magnified by the pandemic. And since 2019, opposition in some countries and at global level to the full realization of the sexual and reproductive health and rights of women and girls has grown. We anticipate it will be evident in the high-level meeting on UHC next year. The first UN high-level meeting on UHC was a critical opportunity to ensure that the needs of women and girls, both as health systems users and as drivers of health systems, were reflected strongly in the commitments on UHC. The second high-level meeting next year will be an equally important opportunity to reaffirm the health and rights of women and girls. In the coming year, you will see and hear the Alliance globally and at national levels. We ask all member states to recommit to the commitments made in 2019 and to take those words off the page and deliver UHC that works for everyone. We want to see processes led by women and that listen to women. During the pandemic, individual women, women's organizations, and women health workers have stepped up all over the world to support health systems, families, and their communities in exceptional circumstances. We now won't ask women to go back to business and gender inequality as usual. Please join and advocate with the Alliance. And in the UHC process, let's listen to women, because women will tell us what they need. Thank you on behalf of the Alliance. I look forward to a very interesting discussion today, and it's now my great pleasure to hand over to Dr. Rupa Dutt, Executive Director of Women in Global Health, who will be our moderator today. Thank you.
Thank you, Anne. Really appreciate the opening and setting the scene. A reminder of what we have, the pathway we have taken thus far, but the challenges that we are facing, a reminder that women must be at the decision-making table, a reminder there is no UHC with having girls' and women's health and rights at the table at universal coverage, and that there still remains a lot of work to do, and we are facing many challenges that are necessary for us to do collective action. So as all of you are tuning into today's event on universal health coverage and gender equality, one of the key things I want to remind everyone is we do have the chat function, in which we encourage you to use, introduce yourself, use it to pose questions. We'll be taking a look at that. Please also engage with us on social media. Our events team will be providing information there. Today's session is structured in a way that we are going to be hearing from two amazing leaders who will be giving keynotes. We'll be then hearing from Alliance partners, and then we'll be going into a moderated panel session, which is an opportunity for your questions. And then we wrap up and continue to push ahead for universal health coverage. So on that note, I would like to invite our first keynote, Ms. Tamalia Barakalia, Deputy Minister, Minister of IDPs from Occupied Territories, Labor, Health, and Social Affairs of Georgia. Ms. Tamalia is a seasoned public servant and leader with experience of more than 2 decades. Before her current role, she was the Deputy Minister of Labor, Health, and Social Affairs of Georgia, and the Director of State Fund for Protection and Assistance of Victims of Human Trafficking. She was also part of New Life Global Network and World Vision Georgia, where she oversaw different development projects. She has studied in the United States at the University of Pittsburgh and the Graduate School of Public and International Affairs at Georgia State Technical University. Ms. Tamalia Barakalia, the floor is yours.
Thank you, and greetings, dear participants, distinguished delegates. It is my privilege to speak on behalf of the Ministry of Labor, Health, and Social Affairs of Georgia at this event. The government of Georgia committed to ensure universal access to health services for all in 2013. And soon after initiation of UHC program in 2014, Georgia ratified UN Convention on the Rights of Persons with Disabilities. This was followed by nationalization of SDG goals. And these developments created a solid policy foundation for policy reforms towards establishing rights-based systems and making health services more responsive to women's health needs. Support provided by our partners, UNFPA, WHO, USAID, and many others, enabled us to better understand the gender dimension of health programs, including reproductive and sexual health needs. Surveys pointed out that factors hindering equal access to high-quality reproductive health services include lack of awareness of the needs and care principles, high level of stigma among healthcare workers and community, misconceptions, and lack of clinical competencies. These factors are even more powerful among women with disabilities. Georgia employed a multifaceted approach aimed at creating enabling legal environment and at the same time building capacity of health and social systems for better serving sexual and reproductive health needs of Georgian citizens. High-level advocacy undertaken by Parliament of Georgia along with community-based advocacy resulted in effective lawmaking process. In 2020, the Parliament of Georgia has approved new law on rights of persons with disabilities. The law outlined the rights of persons with disabilities to have access to services and information about reproductive health, as well as their rights to have a family and children. A separate article on the rights of women with disabilities underlines principles of gender equality, as well as rights to access reproductive health on the equal basis with others. Approval of the law was followed by ratification of the optional protocol of UNCRPD in 2021. Considering leaving no one behind principle, a new 3-year costed maternal and neonatal health action plan has been adopted that envisages rights and needs of the most vulnerable and hard to reach. In order to identify specific needs of women with disabilities, we've put special emphasis on collection and analysis of disaggregated data, as well as strengthening the role of primary healthcare workers. The government program that funds institutional and community care services for persons with disabilities has been modified to include access to sexual reproductive health. Special sessions were provided to service providers to increase their awareness on the rights of persons with disabilities with regard to their access to health, and in particular reproductive healthcare services. To address the need of most vulnerable women with psychosocial needs that reside in mental health institutions, with UNFPA's technical assistance, we've developed guidelines and protocols on perinatal care management and mental health. The documents provide specific recommendations for primary healthcare services, mental health clinics, long-term residence institutions, and reproductive health services to manage specific cases and provide services based on the best practices and scientific evidence. In response to COVID-19, the ministry, with support of UNFPA, has updated clinical protocol and relevant online courses on management of pregnant women during COVID-19 pandemic. Special sessions were provided to more than 130 reproductive health service providers in major regions of Georgia to speed up application of the protocols into practice. Furthermore, to improve the quality of reproductive health services, decrease stigma among service providers, and ensure access to gender-sensitive and rights-based sexual and reproductive health services, the standard operational procedures on family planning and antenatal care were developed and approved. In order to pursue implementation of newly adopted SOPs, UNFPA supported training of more than 90 obstetricians, gynecologists, and family doctors from 5 regions of Georgia in standards of family planning and rights of women, including women with disabilities. Also with support of UNFPA, the first ever accredited and free online learning module for medical professionals addressing sexual and reproductive health and rights of women with psychosocial needs was developed in cooperation with Tbilisi State Medical University and Public Defender's Office of Georgia. The online module is placed on Tbilisi State Medical University Continuous Education online platform, and up to 100 OBGYNs have already completed the course. In addition to all above, Georgia undertook a large-scale labor law reform in 2020. Within the reform, independent labor inspection mechanism was established and authorized to supervise all provisions of the Labor Code of Georgia. The reform aimed at improvement of labor regulatory framework addresses important issues such as anti-discrimination, equal pay for work of equal value, and gender equality at workplaces. The Labor Code determines sanctions for violation of labor norms, in particular, violation by an employer of the principle of prohibition of discrimination, including direct and indirect discrimination, harassment, sexual harassment in workplace, and the principle of reasonable accommodation and the provision of equal pay for equal work shall result in warning or a fine. With support of UN Women, Ministry developed methodology and guidelines on job evaluation and determination of relevant remuneration. The guidelines will be used by employers as well as by labor inspectors while monitoring labor rights protection at workplaces. And in 2021, Georgia joined Equal Pay International Coalition to ensure that we share international best practices. We believe that all the above creates solid legal and policy grounds for increasing the access of women and girls to quality services, thus making solid steps towards achievement of universal access to sexual and reproductive health and rights, as well as provide systemic guarantees for prevention of discrimination in the healthcare workforce. However, challenges remain in the area of stigma and implementation of action plans and service provision documents. Since legislative changes, guidelines, protocols are relatively new, we need to provide more capacity building activities for the healthcare providers and put systems in place for them to adhere to new standards. And of course, we need to do more awareness raising among professionals and population at large to ensure stigma-free and rights-based services for all. Thank you for your attention and this opportunity.
Thank you, Ms. Tamila, for sharing about the very exciting progress on gender equality and very comprehensive approach that is being used in Georgia, especially as you have not only put new policies into place, really had a more intersectionality aspect and making sure that universal health coverage and the health systems are reaching the hardest to reach populations, but you're also looking at the labor practices. We talk about how it is 70% of the health workforce are women, yet when you take a look at who's leading, what kind of working conditions they have, too often they're not being represented or supported the way they need to. So we really appreciate you sharing a bit about the journey from Georgia since the high-level meeting, and we look forward to continuing to learn from Georgia and encourage other member states and governments around the world to continue their quest on gender equality. So again, thank you for your keynote, for joining us, and we look forward to working with you as the Alliance. I now turn and invite my technical team to please have the video up. We are going to have a video message from our second keynote. She needs no introduction in this audience, as Her Excellency Ms. Maria Fernandez Espinosa Garces was the former president of the UN General Assembly during the year of the high-level meeting on universal health coverage. She is also the board chair of Women in Global Health. Maria Fernandez Espinosa is an academic, diplomat, politician with over 30 years of professional experience in the academy, non-governmental and international organizations, and leadership positions within the government of Ecuador. She is regarded as an expert in international affairs in the United Nations on topics such as defense, security, sustainable development, environment, climate change, gender equality, and indigenous peoples' rights. She has clearly extensive experience and inside knowledge of what it really took to have a high-level political declaration that had gender aspects to it. So I'm very excited to hear her message to all of us today as we reflect and look ahead for the next opportunity to advance the agenda. So turning it to my technical team.
Thank you to Women in Global Health, the Alliance for Universal Health Coverage and Gender Equality, Women Deliver, and Spectra Rwanda for inviting me to speak about our shared goal of promoting universal healthcare coverage with a focus on gender equality. As President of the United Nations General Assembly, it was my pleasure to convene the historic first high-level meeting of heads of state and government on universal health coverage. 2019. Political decision makers worldwide were united in their commitment to achieving universal health coverage as a fundamental human right and as the foundation for a better, fairer society. Health and life chances should never be a lottery depending on where a person was born. The political declaration from 2019 turned strong in affirming that gender equality was central to universal health coverage, including meaningfully incorporating a gender lens in health policy making, implementation, and monitoring. As we look forward to the second high-level meeting on UHC in 2023, today's outlook is very different. A lot has changed with the impact of the COVID-19 pandemic. It increased inequalities between and within countries and severely impacted women and girls, making them the victims of a shadow pandemic of gender-based violence. At the same time, the pandemic has shown us clearly why continued investment and momentum for gender equality in UHC, including sexual and reproductive health and rights, and improving the conditions for the health workforce are essential to building robust health systems and global health security. We must develop and implement health financing mechanisms that reduce gender and all types of inequalities, impeding our progress towards universal health coverage. Women represent 70% of all health workers, so the female health workforce is critical to achieving UHC, but only if we enable them to do so. We have an opportunity now to work together to break down the barriers women in health face and build a new social contract for female health workers with safe, decent, and equal opportunities. This includes addressing gender-related health workforce dynamics that affect how women can leverage their role in health delivery, leadership, and decision-making, including the predominance of women in unpaid and informal healthcare. Today, I feel privileged to speak at this event, which reinforces why gender equality and women's rights are critical drivers of health, well-being, and socioeconomic development. Remember that gender-responsive health services, particularly sexual and reproductive health interventions, are health promotive, preventive, low-cost, and cost-effective. We cannot have a fair or healthy world if we leave half of the population behind. I want to take this opportunity to commend civil society's organizations' role in health delivery everywhere. Civil society organizations played a very active role in influencing more substantial outcomes from the 2019 high-level meeting on UHC, and I am a witness of that. As the chair of the board of Women in Global Health and one of the co-conveners for the Alliance on Gender Equality and UHC, the Alliance has my full support for the upcoming 2023 meeting on universal health coverage. I wish you the best in this event and look forward to working with you all to make universal health coverage a reality with a strong focus on gender equality and respect for all women's rights. I thank you.
A special thank you to Maria for her message to all of us, and just turning it to the technical team. If we can spotlight the video, back to the moderator, please. Thank you. There is so much she has told us about the progress we've made, the challenges that we're facing, a reminder of how the pandemic has truly shifted the way how health is delivered. There are many lessons to be learned, but we also know there are greater inequities within and between societies. But as she herself acknowledged the critical role civil society has had and continues to have to push the agenda for universal health coverage and gender equality and women's rights. I can say I've had the privilege with fellow Alliance members here to encourage and nudge her when she was the president of the UN General Assembly. So on that note, it is great to introduce the next perspective we're going to be getting from our Alliance member, White Ribbon Alliance, Kenya. So I asked my technical team, can you please turn on the video that's going to be projected from White Ribbon Alliance?
My name is Sandra Maranya, and I am a gender and health advocate with White Ribbon Alliance, Kenya. A gender-responsive UHC means that the women, girls, and gender-diverse communities we advocate with and for have access to quality, dignified, and safe healthcare. Do you know that healthcare service providers discriminate against clients' gender identity, age, disability, and migratory status when delivering care? By doing so, they are reinforcing harmful and stigmatizing social norms. In Kenya, White Ribbon Alliance has recently joined the We Lead Committees of Action to work closely with women with disabilities, those who living with HIV, those affected by displacement, and those who identify as LGBTQI, to directly engage with healthcare workers, to ensure that they have a deep understanding of their needs, and to ensure that the health systems become more inclusive and more responsive to their sexual and reproductive health needs.
Thank you, Sandra, for your message and sharing a bit about the work that White Ribbon Alliance is doing in Kenya. Again, just asking my technical team, I'm still seeing the pinning not appearing appropriately. If you can please make sure that it toggles. Thank you. For those that will be tuning in with us virtually later, I just want to have that updated. Well, I'd like to next introduce another leader of the Alliance, and someone who has been with Alliance from the early days of its formation, Ms. Eleanor Blomstorm, Senior Manager, Policy and Advocacy at Women Deliver. Eleanor is passionate about social and environmental justice and recognizes that human rights are fundamental for ensuring well-being and a healthy planet. I'm going to turn it to Eleanor to please share with us some exciting updates and tools for all of us tuning in today.
Thank you so much, Rupa, and everyone for this event. I'm really excited to be here today to share with you a new publication. And it's very, very new in that the English version was just uploaded yesterday to our website. And I hope I have some slides, so I hope those can be shared as I'm speaking. But so what it is it's an advocacy guide, and it is called, it's called the Advancing Sexual and Reproductive Health and Rights in Universal Health Coverage and Advocacy Guide. So it's a very basic title, and it's very illustrative of what's inside. What we would like to do today is just kind of, I want to walk you through what's in the guide, but also explain why it's important. We know that as we're looking ahead to the high-level meeting in 2023, that as advocates, we have our work cut out for us at the global level to ensure the process and outcome are gender responsive, to ensure that they advance gender equality, engage girls, women, and marginalized communities while centering human rights, including sexual and reproductive health and rights. But we know that so much of that work really happens at the national level in order to achieve the right to health for all and deliver the quality healthcare services that we need through resilient, equitable, and inclusive health systems. And that really will not happen without civil society advocates. I was really excited to hear the minister from Georgia addressing so many of the issues that were raised in the guide about engaging and addressing marginalized communities, ensuring access to rights-based SRHR through developing and implementing new standards, including with training embedded in that. So I'm sorry, I can't see if the slides are up. Are they there?
Eleanor, I'm not seeing the slides. Again, just flagging it for the technical team.
Okay, just wanted to make sure it wasn't on my side. Well, I will keep going. And basically what we did with for this advocacy guide was we engaged with 19 advocates from 16 countries to really understand what young people need and are looking for, their experiences, and also to include in the document advocacy tips that came from them to understand the processes that they go through, and also to highlight some of the barriers that they experience. So our publication has multiple objectives, and you can use it throughout time. It doesn't have to be that it's for every objective at every moment. But the first objective is to overview key concepts and considerations in the global policy context for gender responsive UHC and SRHR. The bulk of it is to really share selected steps and tips to conduct advocacy at the national level to advance gender responsive universal health coverage that includes sexual and reproductive health and rights. And what we did was focus on a recent guidelines document from the World Health Organization, which has a mouthful of a title called Critical Considerations and Actions for Achieving Universal Access to Sexual and Reproductive Health in the Context of UHC through a Primary Healthcare Approach. And it's a fantastic document, but it's really dense. So what we did is we focused on just one section of that document that's really about looking at sexual and reproductive health strategies that can support universal health coverage. And we broke that down into different steps based on, sorry, it looks like they can't bring up my document, so apologies for that.
Eleanor, yeah, the technical team just informed me that the slides have frozen on their end, so they're working on resetting. So we'll find a way to make sure they're available. Thank you.
Sure. Yeah, we'll put a link in the chat also to it. But so what the document really does is sort of the WHO document is meant to support policymakers more so than advocates. So we've broken down the document to show what these different steps are and how advocates can break them down and think about, what should I consider first? Who should I be speaking to? What are the questions to ask? How can I do some research on this? And so that is the bulk of the document. We also have throughout the document different advocacy tips. And I see this is up, so if you could just move on to the next slide, please. And the next one. All right, so this is the section I'm talking about, advocacy in action. So please continue. Next slide. This slide just shows you how what's on here is a checklist from the WHO document, and this is what we break down in section 2. Please, next slide. And what we've done is highlighted what a government action would be, and then we've included in it tips for you as a national level advocate. Like I said before, there are ideas on how to reflect, for example, on the regulatory frameworks, what exists there. Next slide. And then to investigate, so really dig into what frameworks are out there. Are there different regressive laws that prevent progress on this? And then ideas on how to take action. So who should you be speaking with? How can you help to break down those barriers? How do you engage with coalitions, for example? Next slide. Throughout the document, there are also examples, like I'd said before, of what advocates have done. This Kenya example is really about the constitutional right to participate in governance. And so highlighting how that was done by this advocate. Next slide. Again, more examples are included. And this is what the advocacy tips look like. And I think this is one of the most helpful aspects of the guide. So I hope you have a chance to look through and see some of these. They're all marked with the megaphone. And they're about building allies. They're about how you can look at some of these additional tools that we see here. We explain in the guide how they're useful and how they can support your advocacy, coming from UHC 2030, from WHO and others. Next slide. Then a really exciting piece is helping to craft your own advocacy plan. So once you have all the tools and all the data and you've been digging into this information, you can sit down and craft it looking at these 9 different steps. And so I will allow you to take your time with the document. It'll be coming out soon in Spanish and French as well. Next slide, please. Yes, and so it'll be in multiple languages, and it really offers so much. And we already took down the last slide, but I wanted to leave you with the final quote from one of the young people we consulted with, who said, "You can't have sexual and reproductive health without rights, and without rights, young people won't be comfortable to reach out for services. Without rights, the integration of sexual and reproductive health into UHC won't be successful." So I invite you to enjoy the document, and please give us any feedback. And thanks again to everyone who helped support the crafting of it.
Thank you, Eleanor. It's always very exciting when we have pragmatic tools to use. So really appreciate the fact that everyone tuning in today has a tool that they can go to as a resource as they reflect and create strategies for local action. So on that note, I want to thank our keynotes and members of the Alliance for sharing examples of this their work. Again, this is just the tip of the iceberg. And there are hundreds of Alliance members, organizations around the world that are advancing gender equality and universal health coverage. So I'm going to turn to the next exciting part of the panel, which is our panel session. Just asking the technical team, again, I'm seeing an issue with the toggle of pinning the screen. So as they are updating that, I'm excited to introduce our panel. I'm going to introduce each of our panelists, and then we'll get right into the conversation. So first is introducing Ms. Claudia Seismis. She is a liaison officer for sexual and reproductive health and rights issues, including HIV and AIDS at the International Federation of Medical Students Associations. She is a medical student from Poland, and she is, again, having this position in the International Association for Medical Students. She has worked in the field of sexual reproductive health and rights for 6 years, with special interest in gender equality, gender and sexual diversity and sexual health, and implementing intersectional approaches, including on issues such as climate change, vulnerable populations, and we'll be hearing more from her shortly. We're also joined today by Ms. Chantal Umahuza, who's Executive Director of Spectra, Young Feminist Activism, and she's also a co-convener of the Alliance for Gender Equality and Universal Health Coverage. More to come from Chantal soon. We're joined by Dr. Subhasari Narasimhan, Assistant Professor at the Hubert Department of Global Health, Emory University's Rollins School of Public Health. She's also a member of the Women in Global Health Midwest chapter. She is a public health social scientist who specializes in sexual and reproductive health, maternal and child health, and intimate partner violence in sub-Saharan Africa, Asia, and the southern eastern part of the United States. She has a PhD in community health sciences, and we will be hearing more from her shortly. We're also joined by Dr. Harijot Kosa, a Senior Technical Advisor at the International Planned Parenthood Federation. She's also a member of the Civil Society Engagement Mechanism Advisory Group for Universal Health Coverage, as she is currently working as a Senior Technical Advisor. She has previously worked as a Regional Advocacy Advisor in India for HIV and AIDS for the International Planned Parenthood Federation. She has managed and coordinated dynamically with sex workers, women who use drugs, LGBTQI+ communities, people who use drugs, children and young people, and many other communities that are considered vulnerable, hard to reach. So looking forward to learning from her as well. Again, I encourage you to check out the profiles of our speakers, but looking forward to diving into a dynamic conversation with them as we hear directly about their important work and how they're approaching the challenges that have been outlined today. So I turn to Ms. Claudia as one of the leaders of an international student-led organization. Can you tell us about some of the challenges and opportunities that you and your colleagues are seeing in your work in the field when it comes to universal health coverage and gender equality? How are you shaping your advocacy to support gender responsive health systems and universal health coverage?
Right. Thank you, Rupa, for your question. So actually, I would like to start the discussion on gender responsive health system from the broader perspective, because we need to address gender inequality in the healthcare sector in general. As healthcare sector itself is a stressful environment, it puts it puts at higher vulnerability to discrimination and violence that can be presented as unequal job opportunities, unpleasant working environment due to gender stereotypes, bullying, ineffective measures to protect from sexual harassment, pay gaps, or career choices that are seen only through the lens of gender roles. But gender inequality can also affect patients indirectly, because there are also links between negative workplace relations to overall decreased quality of healthcare. But it also affects patients in another way, because we do not study that thoroughly gender differences in symptomatology. So they are either overlooked or not studied, and that might leave women or transgender individuals underdiagnosed. And finally, this also this gender equality also affects access to sexual and reproductive health and rights services, because they need to be seen as human rights. But and that discussion is especially important now because SRHR is susceptible to be reduced during crisis, and now we see them more often. So setting ground for sustainable SRHR policies and healthcare sensitization is necessary in that moment. And access to SRHR services is particularly important for young people, as they are faced the biggest barriers in receiving the services. And furtherly, this SRHR is not seen as part of UHC most often, they are paid out of pocket, making it exclusive for people with resources that further depends social inequalities. So those are the challenges that we've seen, but the problem is not only the issue of healthcare workforce itself. It starts much earlier in medical education systems, in which we are exposed to discrimination towards patients, teachers, and students themselves. So the IFMSA conducted a survey among medical students around the globe, and the results are disheartening because over 53% of students that took part in the survey. And I need to mention that there is a slight bias because 70% of respondents were women, but overall 53% reported experiencing discrimination towards themselves on the basis of gender on occasional basis up to the daily basis, and 68% observed it towards other students. And this prevalence is also translated to what patients experience, because over 60% of students as well reported witnessing discrimination on the basis of gender towards patients. So one of the most common acts that were acts of discrimination were insensitive gender stereotyping jokes. That was later followed by patronizing tone or sexually inappropriate comments, or assuming certain reproductive choices and family roles, or unsolicited comments on one's appearance based on their gender expression, or being ignored in the discussion. And despite this high prevalence and the variety of experiences of discrimination in almost 30% of schools of students who participated in the survey, no mechanism for preventions or support exists. And this leads me to the conclusion that studying in such an environment does not give positive role models, neither allow positive attitudes to be acquired. And that creates a vicious circle for either not understanding the needs of women in healthcare sector, but also it is an obstacle in creating gender responsive health systems overall, because we fail at its roots. So how IFMSA tries to work on that is, firstly, we presented the survey in AMI conference, which is the conference that gathers academics that are medical educators, but we also educate our members on gender equality, access to sexual and reproductive health and rights services, and also advocacy, how to advocate at the university level, at the healthcare system level, and so on. We also try to ensure safe environments in our organizations through initiatives such as code of conduct. So in every IFMSA event, there are certain guidelines to follow, but also people who support in on the ground. So in case anything happens, there is always someone to support. And we also partner with other organizations in the field. And when it comes to youth themselves, we also work a lot on adolescent health. So currently we work on adolescent health medical framework, which has a big bulk of the chapter on SRHR. And on the final note, I would like to mention how important it is to involve youth in building gender responsive health systems. So it was proven that having youth in designing the programs, the policies, also makes them more inclusive. So in general, in summary, I would like to say that building gender responsive health system must start with the healthcare workforce education, and that includes ensuring comprehensive curriculum, safe educational and working conditions, including SRHR services within the UHC policies. And that change must come from meaningfully engaging youth, including healthcare students, in this process. So that's all from me. Thank you.
Thank you, Claudia. You covered a lot of ground there, and just going back to some of those data points that you shared, the fact that at least half of the survey respondents reported facing some form of sexual harassment, bullying, and a range of the ways that came about the culture and not being supported. Those are pretty heavy numbers. That means 1 out of 2 medical students are facing these issues. And then you also alluded to the fact that your advocacy approaches targeting at multi aspects of the learning journey, from education, working with educational professionals, to also just directly letting the young people and the medical students themselves share and create much more knowledge base on what a comprehensive sexual education would look like. So I think this is, exciting stuff, but also this data reminds us that there is a really critical opportunity to address things upstream and change a culture. You also pointed out that solutions on reporting when sexual harassment, bullying is happening is there aren't mechanisms necessarily out there to do reporting. And it's great to hear that the International Federation of Medical Students Association is not only advocating externally, but internally reflecting. And this just shows the power of youth. And we will be coming back to you. But I'd like to turn to our next speaker and to hear a little bit more about the work that they've been doing in Rwanda. So Ms. Chantal, Rwanda is one of the countries that has made more progress in universal health coverage related policies than most countries. What progress and challenges have you seen toward building, financing, and sustaining gender responsive universal health systems that address sexual and reproductive health and rights? And what role do you see for collective action as you are a co-convener of the Alliance?
Okay, thank you so much. I think it's also really interesting that I'm going to speak right after Claudia, because right this week, my organization, in partnership with the Medical Students Association in Rwanda, who are also part of the International Medical Students Association, we are conducting a community-based campaign and dialogue that is mobilizing more than 300 teachers that are leading the provision of comprehensive sexuality education in primary and secondary schools in Rwanda. Also, more than 200 community health workers, and also service providers that work at the lowest levels. So this kind of partnership, together with the Medical Students Association, we're really leveraging our kind of positions and knowledge and skills in advancing sexual and reproductive health and rights. And we're very much aligning with the universal health coverage framework and the guidelines that is being provided overall in this alliance, but also with the political declaration. So in Rwanda, yes, prior to the discussion and even the adoption the holding of the high-level meeting on UHC, a lot has already been happening in terms of the progressive laws that are in place, the different the different programs that have been put in place. I want to just mention but a few. For many years, I would say for more than 10 years, Rwanda already had a very robust community health-based program system that really goes up to the village level to ensure that, in addition to the low number of medical professionals and service providers, community health workers can continuously provide and extend services. They also introduced way earlier a community health-based insurance that is really making sure that people that are out of the formal labor system, can be able to have insurance that is community-based, that is affordable, and this has been really helpful in terms of accessibility to services, including sexual and reproductive health services. Also, in addition to that, in line with fighting gender-based violence, Rwanda has put in place countrywide what we call the one-stop centers that provide, I would say, almost comprehensive services on gender-based violence that include both psychosocial, legal, medical, and all other support systems in place for gender-based violence survivors and victims. So, and I also want to say that there has been great and tremendous investment in infrastructures, and also Rwanda is one of the few countries in Africa that was able to achieve the Abuja Declaration, where African countries committed to at least allocate at least 15% of their national budgets to health. So Rwanda also is among the few countries that that secure this commitment. And this is a declaration that has been in place for years. So yes, indeed, there are many different initiatives, many different laws and policy frameworks that have set the precedents on what UHC should look like in Rwanda. But definitely we cannot say we're there yet because there are challenges. So what I see as the importance of UHC, the framework itself really pushes us as activists, but also the country, the government, because they're part of the UHC and they've assigned to the political declaration, to be able to analyze the gaps that are there in terms of the legal and policy frameworks, but also in terms of service provision. If we get an example of family planning, for instance, we're very well known that in many countries, let me say in Africa, based on my experience and knowledge of the different systems, those were built on a family-based system where the services, the service provision was more designed for families. That's we talk about husband and wife. And therefore, these kind of systems, even up to date, have remained in place. So the UHC pushes us and also the governments to redesign, to rethink how systems can be more inclusive, how systems can go beyond what was originally designed. So for instance, to include young people, to include women in different diversities, to include female sex workers and all other kind of marginalized groups that before have been excluded from the health system. I also want to see how the UHC framework also is used as accountability tool to continuously remind the governments about what needs to be addressed and how. So challenges remain there. I would say that in terms of really addressing some of the challenges is the advocacy is pushing for a more human rights-based approach. And by this, I mean that most of the times the governments would focus on maybe, let's say, measuring progress using the indicators, more of developmental indicators that align to global or, let's say, regional country indicators and development indicators. It can be in terms of reducing infection, they say HIV, it can be in terms of provision of services, but human rights-based approach push us and the service providers to look beyond to just in terms of the numbers, to ensure that in terms of discrimination, it's addressed, to ensure that there is inclusivity of different groups, especially those that are marginalized. So this is a basis for us to continuously hold the governments accountable to ensure that UHC can be achieved comprehensively and sustainably. I also want to talk briefly about how the collective, the role of the alliance specifically to advance UHC and sexual and reproductive health and rights to ensure that UHC is gender responsive. So I really much have appreciated the work that have been put in place by the Alliance, putting together the toolkit, Eleanor and the group and other people that have contributed to that, including the different advocates. This is one of the issues, this is one of the ways or approach that we need to continuously use, because this is going to be helpful not only for advocates, but for people, for community health workers, for other people that are involved in the health sector that are pushing UHC. So in terms of analysis and provision of resources, that is something the Alliance definitely needs to continuously invest in. In terms of also capacity building, knowledge building, connecting the dots, because definitely we know that UHC, the discussion on UHC and the political declaration started in 2019. But prior to that, we have legally binding global instruments. We have very conventions where issues around sexual and reproductive health and rights are well spelled out. We have the CEDAW, we have the Maputo Protocol in Africa. So it's also to continuously connect the dots in terms of other instruments that we have that can be used to continuously make sure that UHC can be achieved and can be gender responsive. So I want to be brief and stop here, and hopefully we can share more during the dialogue, the discussion with the participants. So thank you so much.
Thank you, Chantal, for providing insights of what is happening in Rwanda, how your organization is working on these issues, what progress you're facing and what challenges, but also reminding us of the regional political commitment on universal health coverage and investing in health systems specifically. It's important to leverage regional commitments to advance agenda. So again, thank you for these insights. We clearly need to continue to reflect on them and work through collective action, as you pointed out. So we'll be coming back to you as well. But thanks for highlighting the importance of national work and the role of the Alliance for Collective Action. And now I turn to Dr. Subasari. The question really is about, the analysis and what you were seeing. Despite commitments made during the 2019 Political Declaration on Universal Health Coverage, women are being impacted by growing backlash on sexually reproductive health and rights. How is this affecting the achievement of universal health coverage? Would be great to hear your reflections from your local context and the communities you work with around the world.
Yeah, thank you so much, Dr. Rupa. I'm going to reflect today a little bit when we talk about growing backlash. Actually, in the last several years, I feel like there has been incredible gains made in sexual and reproductive health and rights across the globe, and including particularly for abortion rights. And today I've been asked really to reflect on the impact of overturning the constitutional right to abortion in the United States, or the Roe decision, the implications of that, which are being felt pretty clearly, and then also the connection with the achievement of universal health coverage and how universal health coverage must consider sexual and reproductive health and rights. So when we think back to 2019, we can clearly remember Sigrid Kaag's argument about SRHR being integral to the movement for universal health coverage. And they highlighted that more than 60% of sexual and reproductive health services are financed out of pocket by patients. And this burden is felt disproportionately really on women and girls. So in SRHR, which is not only a crucial part of healthcare, it's a crucial element to achieving gender equality. And universal health coverage really remains an important vehicle for ensuring access to vital healthcare services. But central to SRHR and to reproductive and bodily autonomy is this right to decide when to have and not to have children. And a crucial component of this is the safe right to abortion care. And this is part of an essential, comprehensive sexual and reproductive health care package. Yet the fight for safe abortion care has often been a whisper. It's often been in the background rather than a shout when we talk about sexual and reproductive health and rights across the globe. Yet we sort of saw the implications of this in June in the United States when the US Supreme Court overturned Roe v. Wade, thereby eliminating for US citizens the constitutional protection for abortion and returning those decisions to the state legislatures. I would sort of argue that this isn't an example necessarily of overall backlash against sexual and reproductive health and rights, but rather a political project that was set forth in 1973 when the Roe decision was made. And immediately after that, after the loss of Roe, states moved extremely quickly to ban abortion in early stages in pregnancy. They used inaccurately named laws, such as heartbeat laws and other gestational abortion bans, some of which were so extreme that they contained no exceptions for the health of the life of the mother, and or for pregnancy resulting from rape and incest. And if you look at political debate, which I have spent a lot of time doing, it was very clear that this was the movement, and this was what legislatures who are anti-abortion were doing in state houses. In the state that I am from, Georgia, which is located in the southern US, only a mere 4 weeks after the fall of Roe was the passage of HB 481, which was a ban on abortion at the detection of embryonic cardiac activity. And to put that into context, in practice, this results in most people being turned away at or prior to 6 weeks after their last menstrual period. This is before many people even know that they are pregnant, that they are able to take a pregnancy test. And additionally, only a day ago at the federal level, Senator Lindsey Graham proposed a federal ban on abortion at 15 weeks gestation. So in the US, the abortion experience or abortion care, the abortion experience is pretty common. Almost 30% of women, most of whom are already parents, will have an abortion by age 45. Yet the lack of abortion care overall is not a new reality for most people. But the loss of Roe really cements this reality that abortion care is out of reach for many, particularly those without substantial resources, and the consequences were immediate and are chilling. So recent data from Texas, another southern state in the US, found that healthcare providers have been compelled to delay or outright deny care until conditions qualify as medical emergencies. We have extremely clear data that abortion restrictions at the state level also adversely impact other health outcomes, including maternal mortality. And this is a particular problem for US Black women who already suffer from maternal mortality rates 3 times higher than white counterparts. So to be clear, the impact of the fall of Roe is being felt on the shoulders of the most marginalized in this country. And no data to date shows that these severe abortion restrictions or any abortion restrictions serve a public health good. Recent evidence from the groundbreaking Turnaway study showed that women who were denied wanted abortion suffered from greater physical health consequences, were more likely to live in poverty, were more likely to raise their children in poverty, and were more likely to stay in violent relationships years after that denial was made. Denying abortion care means denying women are the best judge of the needs of their lives and their life trajectories. And the consequences I am describing here are not new. This is kind of a familiar story in nations across the world. And therefore, the consequences of the post-Roe environment are not limited to the US. Ultimately, regression of abortion policy in the US may bolster anti-abortion sentiment globally, undermining major gains made recently in abortion rights and gender equality. We will and may see greater surveillance, scrutiny, and criminalization of pregnant people, as well as increased barriers to funding for abortion care, even in places where abortion remains legally permissible. In the US context, abortion care has always been an out-of-pocket cost, and many people patchwork that cost through various funds. Research from the University of California, San Francisco showed that due to substantial state and federal restrictions on abortion coverage, women often bear the brunt of paying substantial out-of-pocket costs for abortion care, regardless of whether they have private or public coverage. In their study, more than half of women surveyed reported that they delayed seeking abortion care because of the need to obtain funding for the service. For some women, this paying for an abortion constituted nearly 1/3 of their monthly income. And just to put this in context, the median cost at that time during the study was around $400, the median out-of-pocket cost, $400 US. So these restrictions of coverage and ultimately the cost of abortion care are only going to increase in the post-Roe environment as abortion becomes more difficult to obtain. So in reflecting in this post-Roe environment in the US and also on the repercussions globally, we need to consider the costs and barriers to abortion care as critical to sexual and reproductive health care overall, and to the fulfillment of universal health coverage, as a lack of access to sexual and reproductive health care puts many people at risk. Currently, each year in low and middle income countries, around 35 million women continue to have abortions in unsafe conditions, resulting in lifetime morbidity or overall mortality. At the heart of universal health coverage is really this commitment to equity, so that all individuals who need health services are able to get them regardless of their financial resources. Abortion access is critical to achieving gender equality and universal sexual and reproductive health and rights. UHC ensures that access to services for all and includes protecting, respecting, and fulfilling the rights of people who can become pregnant while eliminating the political barriers that prevent people from enjoying the right to health. We must consider abortion care in the fight for universal health coverage and as part of the greater fight for universal sexual and reproductive health and rights. Thank you so much, and I'm happy to answer any questions.
Thank you, Dr. Subasari. Very interesting, data that you've shared with us, really clearly showing the gender inequities, the increased burden on women. As someone that is a practitioner in the United States, I have, can very much, many of the points you've talked about resonate. The confusion of what is considered legal or not is leading to health systems not providing care, and abortion care is health care. A reminder that women are the most affected by this, and women are the most marginalized groups are most affected by this. And you also gave some very clear data on the cost, the expenditure out of pocket, and how that impacts the ability for women to access safe abortion care here in the United States. So really looking forward to further discussions on how advocacy can be part of the solution to push back against the pushback. So now I turn to Dr. Harijot Khosa, and looking forward to hearing your reflections on, since the 2019 Political Declaration on Universal Health Coverage, the world has been hit by the COVID-19 pandemic. How do we leverage lessons learned from the COVID-19 pandemic for the next high-level meeting in 2023? And how will the civil society engagement mechanism for universal health coverage bring the perspective of civil societies to universal health coverage 2030? Again, turning to you to reflect on what we can expect.
Thank you so much, Dr. Rupa, and good evening, everybody from India. And the first word that I have on my mind is bounce back. There is no other way out. We have to bounce back. And when we talk about, we talk about how do we bounce back, there has been a lot of experience that COVID has given us. My experience of being engaged with the ACT Accelerator pillar, there was a lot of rush when COVID came, and so many partners came together at global level, at regional level. So many task forces were formed, and COVID communities were initially not there, but later on there. And there was a lot of push to get commodities. There was a lot of push to get vaccines, but not enough itself, because there was no investment in health systems. How we aimed to put shots in people's arms, but how do we get there? We did invest a lot in diagnostics. We did invest a lot in vaccines. We did not invest that who is going to get the vaccine first. A woman in a household in Global South is going to be the last one to get the vaccination. Why? Because we are not calculating how our health system is going to work, how the gender inequalities are going to play in, and how COVID and women affected by long COVID are going to work into this interplay. COVID-19 pandemic also pushed the world farther away from the 2023 targets set by the political declaration, which included progressively covering 1 billion additional people. Where are we with that? Just a year, how are we going to answer to that responses? Building it up on the CSCM on our perspective, 2023 UN high-level meeting on UHC, it is an excellent opportunity. It is an excellent opportunity to get UHC back on track, to ensure that we prioritize investments, we are able to strengthen the health system, and actually no one is left behind. Because right now, so many people are falling out. We really need to bounce back. And how do we bounce back? We really need to ensure that everyone's health is being taken care, catered to, and our health systems are robust to reach that last mile, which we have to reach. And how do we ensure it? We need to ensure that we have access to health, but quality health services, which right now, because of COVID, as you know, our friend just highlighted, how we are facing the financial hardships. How are we planning to work through it? Out-of-pocket expense, like so true. If you have to spend money, first it will go to, in the pyramid of women, how we all know how it's going to be distributed. Out-of-pocket expenses have increased, and how is, and talking of my own experience, I had COVID. I was living in a hospital. My house is in the front of emergency, but I did not get a bed. And it's not that it's the health system that failed me also. And I was not getting oxygen cylinder. I was like, just praying that somebody comes and saves me, So I think right now, how are we ensuring that we are planning, we are able to get opinion, like, being a woman, I don't want to be the beneficiary. I want to be there. I want to be there when the decisions are being made, when the discussion is happening as to how are we going to plan for the next steps after COVID? How are we planning to bounce back to achieve our global targets? In last 2 years, what we saw, that COVID pandemic had a lot of investment from communities, from CSOs, from various platforms. We all got in action, but is it replicated or coming down or percolating down to regional or national levels? Are the governments able to engage communities and CSOs enough to understand that, okay, we have this learning, COVID has hit us, what next? We need to have that kind of dialogue. And it's been like that, how do we catch up? And we need to have meaningful social participation. These words actually mean a lot but we have to reflect on it. How do we decode it? We need meaningful social participation so that there is a trust building, there is accountability, and that needs to be there at the epicenter of 2023 HLM, nothing without it. If we talk like, I also want to share that as CSCM, since 2019, we have undertaken consultations at countries level. We have reached out to 18 countries, and these consultations have been with communities and with the civil society representatives to understand how are we faring on the UHC commitments. And these consultations have made us to realize that COVID pandemic has, what do you call it, amplified the inequalities. COVID has some secondary impacts, and who are the worst affected? Worst affected are marginalized, are vulnerable populations. And when I talk about marginalized population, I want to highlight about transgender women. I want to highlight about women in sex work, women living with HIV, young girls, women who use drugs. How are we responding to, the last mile? How are we reaching out to them? Are we able to reach out to them with necessary care, especially with sexual reproductive health services? And I'm not even going to talk about sexual reproductive health rights. How is this world faring on those commitments? If I talk about that, we have commitments, but when we talk about, like, it's enough of lip service. We really need to ensure that no one is truly left behind. And especially we need to get vulnerable communities at the epicenter. At the 2019 political declaration, UHC stated that policymakers must endeavor to reach the furthest behind first. I think that first is something that we need to really think around. We really need to push our efforts. We really need to come together as communities, as civil society members, as platforms. We really need to join our efforts. And, also we need to have some joint initiatives to push for the last mile, because we have to just reach there. That is the only target we all have now. And we also hope that you all join us and join us during the UHC Day on 12 December. And, we all have to bring together our investments, our passion, and we have to, so that we are able to achieve UHC, what we all have been talking, and we've been talking about our commitments. So I think I have nothing more to add. So thank you so much for actually talking about it today. Thank you. Thank you, Rupa. Yeah.
Yes, thank you, Harijot, about your reflections on especially highlighting what has happened during the pandemic and pointing out that the most vulnerable, most marginalized women are being hit the hardest, and to really think about the last mile, but also reflecting on the platform of civil society engagement mechanism, which is a formal platform in the UHC 2030 space, and to really share how there has been opportunities for community engagement and what you are hearing from communities all around the world in the consultations that CISM has been hosting. So really appreciate hearing that. I'd like to actually encourage our panelists to take a look at the questions that have come in, and I would like to also encourage our attendees. Please use the Q&A function of Zoom to submit your questions, and all speakers, please do turn on your videos as we get to this next rapid fire question session. And the first question that I'd like to pose to our speakers, and it will go from top to bottom in order, is one of the questions that came in is, what positive changes have you seen for women, and how has that made a difference when it comes to advancing gender equality in the context of universal health coverage? So I'd like to first turn to Claudia, just mindful of time, if you could please keep your answer focused to a minute. So turning to you, Claudia, first.
Thank you a lot. So the first thing that actually I thought about is how we also start to perceive self-care, which I think is extremely crucial when we speak about SRHR, because it gives women much more agency in taking their reproductive choices and overall decisions on health. So I believe now we see self-care as something that can help to achieve full universal health coverage. Yeah, so I guess that's pretty short from me.
Thank you, Claudia. I'd like to turn to Chantal.
Yes, kindly, Rupa, repeat the question.
Yes, so an example of positive change that you have seen when it comes to women.
Yeah, so women's health, and specifically when they are able to realize sexual and reproductive health and rights, and more specifically bodily autonomy, the positive changes that you start seeing is that it also contributes directly or indirectly to their economic empowerment. So you see more women increase in political participation, for example. You can also see results when it comes to participation in the labor force and other economic activities. So, and that's why, for instance, in our work, we constantly link these kind of aspects, that health, economic empowerment, and other gender issues are really intertwined, and that we cannot achieve one without the other. So the positive impact on advancing UHC translates into women's economic empowerment and other kinds of better livelihoods, and also better families together. So these are some of the positive changes that you can start seeing when there is increasing investment in women's health and sexual and reproductive health and rights.
Thank you, Chantal. I turn to Subasari.
Yeah, for sure. Thank you so much. I think building on the last two speakers, I've seen a lot of growing interest by women, and particularly younger women, in political participation and how they can advance advocacy both in their local communities and at national and international levels. And I feel like that's been an incredible move forward.
Thank you. And then turning it to you, Harijot.
Yes, so thank you. Actually, we talking about this is the first positive thing which I feel that has happened, that we are here having dialogue about it. We are realizing that there is a need, and also talking about the intersections, the positive, no movement can work in silos. When we are talking about UHC, when we're talking about women's rights, we're talking about COVID, it's not that these are some different pillars. Everything has to come together, then only we can achieve UHC. And I think that that's very important, that we are having this interactive discussion. We are able to integrate our perspectives, our learnings, and how do we, I'll again say, bounce back. And I think this is a good point to start with that. Thank you.
Thank you, Harjot. We have a few other questions which I'd actually like, depending on the panelist, to chime in. One is coming in about community health workers. We know that community health workers around the world are majority women. We know in the health sector, half of women contribute is in unpaid, underpaid. We estimate at Women in Global Health, the report released recently showed that there's at least 6 million women around the world that are unpaid when it comes to delivering healthcare. So what roles do you see community health workers to ensure that universal health coverage is successful? So I'll just see if there's any of our panelists that would like to answer that question, and then we'll go to the final question of the panel. Anyone want to chime in on the role of community health workers? I see Dr. Subasari, you were about to unmute.
Yeah, I think community health workers globally are, vital to ensuring that universal health coverage continues and also reaches the most marginalized groups in different nations. I think we also have to consider how we support community health workers as they do their job. I think often there is a movement to supporting health workers in other areas, for example, physicians or nurses. And in that movement, the needs of community health workers are often go unaddressed, and often they're not consulted when new initiatives or new programs are rolled out. And that's unfortunate, because your community health workers are usually the people who are on the front lines actually implementing programs that really make change. So I would say, their role is essential. And then their participation in understanding how we can move universal health coverage forward is also essential.
Thank you for those reflections. So we're down to the last few minutes of this very exciting panel. Really thank the esteemed panelists. As we come to close, I want to highlight a couple questions that have come in, and hoping the panelists may be able to integrate some points into their final closing question. One is really around how can advocates and other relevant stakeholders influence governments ahead of next year's high-level meeting on universal coverage. Another one is really around how can we really ensure that issues are not addressed in silos, but that they are really cross-cutting, and that we really have an intersectionality approach when we look at gender. We've already seen this come up in some of the answers from our panelists today. And how do we address social determinants toward universal health coverage practically? Now, even these two questions show that we're touching on the surface. There is a need to continue to unpack and work collectively together. So the final closing question for our panelists is, for the upcoming 2023 high-level meeting on universal health coverage and beyond, what is your recommendation to ensure stronger collective action and achieve gender responsive universal health coverage with women and girls and their rights at the center? Again, a reminder, if you can keep your answer to lightning speed of a minute. So on this note, I'm actually going to work backwards. If we can please have Dr. Harjot kick us off.
I'll again go to the point that we were talking earlier. How do we ensure it? We have to reach out to the last mile or the last point. And we have to see that, our intervention or the commitments that we are planning or what we are deliberating, we are just leaving no one behind. We are ensuring that, our endeavors are supported by government, by political will. We have to ensure that we have, communities and CSOs as decision makers. We need to specifically highlight how COVID has left the system, how do we bounce back on the health systems also. I think if we are prepared with that kind of perspectives and discussions, and also we get Global South to the, not as beneficiaries, but as decision maker. And I think it's high time that we just build on community intelligence, what has worked, what has not worked with prior commitments. I think that is how we should be well prepared with.
Thank you, Harjot. I turn to Subhasari, please.
Yeah, sure. So I talked a little bit briefly about how I thought, abortion, chipping away at abortion rights in the United States was a political project. And so we essentially really need to focus on transparency and holding both policymakers and lawmakers accountable, particularly as people and citizens within countries watching what they say and what they do in legislatures and legal landscape areas across the world is really important, and holding them accountable for what they say. Often in the US, the things that state lawmakers have said in state houses have gone unaccounted for. And there's a huge need to hold both them accountable, but also to stand in front and say, this is what the outcome of this law is going to be. So that's one way that I think that we can ensure this interest.
Thank you for that succinct answer. I turn to Chantal.
Thank you. Yeah, I think it's in line with what Dr. Harjot said in terms of how the pandemic has really showed, and we've all learned from what the pandemic has exposed into the weak health systems, and also who gets more affected when we have something like the pandemic that we had, in terms of those that are most vulnerable, but also in terms of accessibility to services. When public transport was closed down, for example, the role of community health workers at the time in ensuring, for example, delivery and all other services that women required at the time. However, I really want to point out that the emphasis and the investment and the whole approach of community health workers sometimes is almost gets at the close as the same as the burden or the over-reliance of unpaid care work of women. So that's where the issue around, yes, community health workers is a component that is crucial, and we need to prepare that and have really positive messaging towards the high-level meeting next year. But it should not replace, it should not stop us from continuously pushing for a substantial investment to the health sector. Right now, even though, yes, we rely on community health workers, the majority of runners rely on community health workers, but we also have doctors and health and nurses and midwives who are still not well paid. So we also need to continuously push for the health sector investment and not just rely on women's unpaid care work, because majority of community health workers are women. So, and beyond that, so that's where, as part of the advocacy towards next year, we need to talk about financing for health. We need to link with maybe some of the political kind of discussion that have been happening on the continent that are around domestic resource mobilization, issues around illicit financial flows. They are not very separate from the discussion on financing for social sectors like education and health. So for me, I think it's also to identify some of the topics and areas where some states and governments are really keen to listen, to lend an ear in terms of domestic resource mobilization, and looking to how this can improve the health system system that we have and can be able to reach the target of resource mobilization that we are looking for, or that we're taking as an excuse to not invest better in health system. So that is, for me, something that we need to also take on board when we're going to the HLM next year in terms of financing and where the resources come from, and holding also other developed countries accountable to their commitments in terms of their contribution to this. Thank you.
And thank you, Chantal. I think you have really touched on, we can only achieve this if there's real investment, and we need a conversation just on that, as you reminded. Claudia, we're right at time, so to bring us home, if you could just give your closing point. We're not hearing you, Claudia. Yeah.
Yes. Yes, sorry. Internet issues. So we advocate for health inequality policies, which means that universal health coverage. Oh, am I breaking?
You're breaking up a bit. Do you want to just start again? And I just ask our attendees if you could please give us 2 minutes to wrap up. Claudia?
All right. Maybe I will turn off my camera if that's better. All right. So as the IFMSA, we often advocate for healthy health policies. That means that universal health coverage is considered in other stakeholders, only in ministries of health, but also in other stakeholders such as social protection and so on. And that leads to understanding also that sexual and reproductive health and rights must be understood here as a part of health overall. So in all of the decisions of other stakeholders, SRHR also needs to be taken into account. So in all of those policies, we need to ensure that SRHR is there. And this can only be achieved when we comprehensively listen to voices of all society, people from diverse communities and civil society organizations. That also includes those youth-led. So that's all. Thank you.
Thank you, Claudia, and really great final remarks. I want to again thank all of our speakers today. I want to especially thank the Alliance for Gender Equality and Universal Coverage. For those of you tuning in, if you have not joined the Alliance yet, we invite you to join the Alliance. We clearly have heard from our keynote speakers, our Alliance members, our technical speakers today about the important work that is needed moving forward, the need for collective action. And it's been an inspiring discussion. It has reminded us that universal coverage, to be universal, must leave no one behind. It must reach all women and girls. It must be gender responsive. So do stay with us on this journey to the next UN high-level meeting on universal coverage in September 2023. Yes, that is a year away from now, but we know how much work is needed to advance the agenda, how much work is needed to make sure we don't roll back, because that rollback is happening. And so encourage you to stay connected with each other and to stay connected with us at the Alliance. On behalf of all of the Alliance and the co-conveners, again, thank you for being with us today. I'd like to now close the meeting. We will be following up with sharing those resources. Continue to engage with the discussion on social media with us. Have a wonderful rest of your day and week. Stay safe, stay well. Thank you.